Hi, hello, this is Shahul Irfan. Welcome back to my YouTube channel. It's been so long since I posted any videos on my YouTube channel. Today what we are going to see is newborn resuscitation and routine newborn care. Without wasting much of time, going to the basics. First of all, I will explain you about routine care which you have to do with every babies and then followed by newborn resuscitation, which is a treatment part. This is a routine part, okay, fine. So before going to the topic, we can first see what are the 5 cleans, which is a neat question. 5 cleans that has to be followed in an OT theatre whenever you are receiving a baby, either in the OT theatre or in the labor ward. See, it is clean hand, clean surface, clean umbilical cord, clean blade and clean cautery. You can very well remember that these are the only 2 things which is kind of different, hand and cord, and the remaining 3 is completely related to the umbilical cord. Fine. So clean umbilical cord procedures, we have to have a clean cord blade, and clean in the sense sterile. It has to be sterile because it will lead on to sepsis. If it is not sterile, it might lead on to sepsis. Okay, fine. Clean hand and clean surface has to be there. Okay, fine. Coming to routine steps, I will just tell you like a story which used to happen in our college. I am from Stanley Medical College. This is the work of a called CRD. We'll have a 24-hour duty where we'll have to attend all the labors and we'll have to attend all the deliveries and do these routine steps. Fine. So, in an OT theatre or in a labor ward, the pediatrician will be standing next to the physician with a pre-warmed towel ready to receive the baby. So, once the baby is out of the mother's womb, either from a vaginal tract or from the LSCS, the physician will immediately hand over the baby to the pediatrician. So, pediatrician will hold a towel which is already pre-warmed, clean, sterile, and he will receive the baby and immediately shift the baby to the incubator. You know, because you know that, for example, let me tell you, in OT theatre, no, the temperature, ideal temperature will be 25 degrees Celsius, which is not a favorable environment for the baby. Baby has to be baby's normal body temperature. See, normal body temperature of a baby is 36.5 degrees Celsius minimum, 36.5 degrees Celsius to 37 degrees Celsius. Whenever the room temperature is lesser than this, the babies are more prone for hypothermia, because adults have fat, babies don't have much of subcutaneous fat, babies don't have proper mechanism to reproduce heat. They develop only in the later half of their infancy. That's why we'll have to be very careful as far as hypothermia is concerned. So what are the steps that can prevent this hypothermia? Coming to the routine steps. First, pediatrician will receive the baby. It is also the responsibility of both physician and pediatrician to properly tag the baby. Okay, the tag has to be tied on the baby's right hand as well as on the mother's right hand so that we don't mix the babies. Fine. Then it has to be on a pre-warmed towel. The pediatrician will receive the baby on a pre-warmed towel, and we'll have to wipe the baby. Okay, wiping the baby is very, very necessary, because the baby will be losing lot of heat through his head, through his body surface, because the baby would have already been covered with this amniotic fluid, vernix gaseosa. We have to immediately wipe that so that we can reduce the heat loss. And then we'll be shifting the baby immediately to the incubator, where the incubator will already be switched on. We'll have a ideal temperature of 36.5 to 37 degrees Celsius in the incubator. Fine. Then once the baby's hypothermia is maintained, once the hypothermia part is done, then we'll have to start a routine suctioning. We'll use baby's NG tube. We'll be sucking it. We'll be making suctioning of the mouth, that is followed by N. This is one of a very important neat question. And the reason for making suctioning on the mouth before nasal cavity is to prevent aspiration. Okay. If we do suctioning of the nasal cavity, no, it will lead on to aspiration before mouth. Fine. After suctioning, we will be using, in our college, we will be using the same NG tube to check the patency of anal canal, so that we are ruling out the patent, imperforate anus and anorectal malformation. So we'll have a lot of methods to screen the clinical anomalies. For example, let me tell you, in CTEV, just we can do a simple procedure by which we can find out whether the baby is having CTEV or not. Just assume this as a shin of tibia of the baby, leg of the baby, this is the foot of the baby. We'll have to dorsiflex the baby's foot and try to touch the baby's foot on the shin. If that is possible, then the baby is normal. If that is not possible, then there are increased chances the baby might have congenital talipes equinovarus. Number 1. Number 2, what we used to do, everyone used to do, we'll be making the baby prone and check for the spinal anomalies, whether the baby is having spina bifida or any tough hair, anything. We'll be making sure that at least we'll be screening that there is no gross congenital malformation. Fine. After done, so coming to the part per se, this lesson per se. See, this is very, very important, bro, and quite confusing as well as very important as well as NEET examination. Any competitive examinations are concerned, this is very, very important. See, I will tell you there are 3 things. One is BLS, Basics Life Support. One is ATLS, Advanced Traumatic Life Support, and the other being Pediatric Newborn Resuscitation. Okay, fine. In BLS, it is always CAB. BLS is the work of an anesthetist. Just remember, or a medicine department, whenever there is cardiac arrest in the medicine ward, they will be making sure, they will be taking care of circulation first, followed by airway, followed by breathing. As far as ATLS in trauma, airway is even more important than breathing and circulation. So they will be following this ABCDE protocol. A for airway, they will first check the airway because aspiration is so very common in traumatic patient. That is followed by breathing. They will rule out pneumothorax. They will be checking the circulation. Then they will be putting a disability score. That is what GCS is all about. And there will be exposure. They will be exposing the whole body to see any other traumatic wound. As far as pediatric resuscitation is concerned, it is TABC. Okay, because I told you temperature is very, very important in the baby. Management of temperature has to be the first because babies are very, very prone to go in for hypothermia. Fine. So I told you how we manage the temperature. We'll be pre-warming, we'll be wiping the baby and all this stuffs like that. Coming to airway. Bro, if you want to make sure that the airway breathing is normal, just look at whether the baby is crying or not. If the baby is crying, then it automatically means that the airway of the baby is patent, normal, as well as breathing is pakka. Fine. So we can make sure that if the baby is crying, we can make sure that AB is normal, and circulation, just keep the pediatric slit over the chest of the baby and see whether the heart rate is more than 100. If the heart rate is more than 100, no, we can make sure that the baby is having normal circulation too. And number two, we can also make sure that whether there is any cyanosis or not. By looking that, we can make sure that circulation is normal. This is what TABC as far as pediatric people, newborn is concerned. See, now comes the problem. Now comes the exact role of pediatrician. Everyone can do this. Even a CRRA, even a normal MBBS student can do this. But as far as resuscitation is concerned, that is the role of a pediatrician. So what we will have to do if the baby is not crying? See, the observation starts from the moment the baby comes out of the mother's womb, either in the form of LSCS or not. What we'll be seeing is, we'll be making sure whether the baby is vigorous or not. Okay, we'll be making sure whether the baby is vigorous or not. What is the criteria for a vigorous baby? There are 3 criteria. This is also one of the very important Neet question. See, number 1, when the baby is crying, vigorous in the sense baby is vigorous, which means the baby is healthy. As far as baby is crying, baby is healthy. That is the only phase of life where people will be happy looking at us crying. Fine. So when the baby is crying, it is a vigorous baby. When the baby's tone is normal, it is a vigorous baby. Tone in the sense, how will we be checking tone? No, the moment the pediatrician take the baby out, when the baby's arms are flexed, legs are flexed, then the tone is normal. If it is not flexed, the baby is kind of floppy, then the baby is not vigorous. We'll have to manage. Fine. Number 3 is crying, tone and heart rate. If the heart rate is more than 100, then the baby is vigorous baby. Exactly opposite to that, the baby is not crying. The baby is not crying. The baby's tone is not proper. Either the baby is floppy or literally the tone is not at all there. And if the heart rate is less than 100, then it is not a vigorous baby. It is a non-vigorous baby. So the management comes as far as this non-vigorous baby is concerned. We will have to immediately manage them. And there comes the role of the pediatrician. Fine. So what we'll have to do? See, actually this is a complex kind of tabular column, but I will make it simpler. Okay. For you, I will make it simpler. Fine. Just see, bro, I will tell you one advice. You will have to remember thousands and thousands of tabular column when you are in the PG preparation phase. Okay, lot of scores, lot of tabular columns, lot of schematic diagrams, and it is very volatile too. See, it might be very interesting to study this now, but when I ask the same question after 1 month, no, you won't be able to reproduce. So how to remember a table? How to overallly know about something? Overall, this technique you can apply it to any tabular column you study, any schematic diagrams you study, any flow charts you study, you can apply this. See, don't go step by step. First of all, never go step by step. 1 plus 2 is equal to 3, 3 plus 2 is equal to 5, 5 plus 2 is equal to 7. If you go step by step, you will forget. Don't go step by step. Okay. First of all, when a tabular column is, let me tell you, this is just a technique which you can see. Let me assume that this is a tabular column. No, let us keep this. A is followed by B, B is followed by C. Just assuming. Never go with A followed by B, C and all. First whenever a tabular column is concerned, first see what is the significance of the tabular column. Why we are studying that tabular column, or why we are studying that flow chart. Significance of the tabular column. Number 2, outcome of the tabular column. Overall, if for example, if the heart rate is, like don't go with, I will tell you in detail, but just remember, see the very significant point in the tabular column. Number 2, see the outcome. Outcome na, how we will have to manage. If for example, let me take Childbirth Scoring. First, don't study Childbirth Scoring. It has B for bilirubin, INR and all. No. First, see why we are studying Childbirth Scoring. What it is used for. It is used to prioritize the patient. It is used to see whether the liver is compensated or not. This is adults. This is not pediatrics. Pediatrics, we have Childbirth Scoring, pediatric and stage liver. I'm just telling you. First, see the outcome. What we'll be doing? What is the score? Minimum score is 5. Maximum score is 15. I guess 15. I forgot. So, if it is 5 and 6, it is decompensated. It is 7, 8, 9, 10. It is like A. It is 7, 8, 9, 10. It is B. 10, 11, 12, 13, 14, 15. It is C. First, see the outcome. Don't study by step, because you will forget. Okay, that is why I'm telling you. Number 3, see the most significant step. First, remember the most significant step. Then you can remember every step. Okay, ba. So if you do this, you will be able to at least remember the significant point. Bro, in Neet exam, no. Another one technique that let me tell you. They won't ask every steps, bro. There will be significant 2 or 3 steps in every tabular column. Only they will be testing that. Take it surgical stages of tumors or pediatric resistance, anything, they'll be asking only the significant point. You will have to find that significant point to remember. Okay, we can't remember everything. You might be able to remember this today, but when I ask you after 1 week, you won't be able to remember. Fine, this is some of the techniques without wasting time. Let me go to the newborn resuscitation. Okay. See, I will make you easier. Okay, I will make you easier. Just don't try to look at all the things. Just to see whether the baby is vigorous or not. Just apply the 3 criteria and see whether the baby is vigorous or not. So we will have to manage if the baby is not vigorous. So how we will be managing is number 1. First, the role of the pediatrician. I told you, the moment we take the baby out of the mother's womb itself, the pediatrician will find out whether the baby is floppy or not, whether the baby is crying or not, whether the baby's tone is normal or not, whether the baby we will have to resuscitate the baby or not, we will have to intubate the baby or not, we will have to give chest compression or not. All these things the pediatrician, the second he sees by experience, he will find out. But let us go with a routine step process, okay? If the baby is not vigorous, you will have to be super attentive. You can't do the routine resuscitation. You will have to be very quick. See, here when the nurses are very happy, smiling, and chief ma'am is teaching us very happily because it is a mannequin. This is not happen. This will not happen in the reality. Reality, you will have to be so serious. Your heart rate will go more than 100 because it is very, very important. First minute of the newborn resuscitation, if the baby is not crying, is called the golden minute. If you miss that first minute, the baby's prognosis is very poor. The baby can go in for hypoxic ischemic encephalopathy. You will have to be very careful when you are going for resuscitation when the baby is not crying. It is an emergency. It is an emergency. Okay, fine. So coming to the resuscitation part, see whether if the baby is not vigorous, immediately check the heart rate. And we can divide if the heart rate is more than 100 or less than 100. If the heart rate is more than 100, you can bring your heart rate to less than 100. You can be kind of relaxed. Okay. If the heart rate is more than 100, the baby is not crying, or if the baby is having some labored breathing, just to go with oxygen supplementation by using hoods, masks, anything. Nothing to be done. This is more than enough. The baby will be normal. Okay. If the heart rate is less than 100, there comes the problem. Heart rate is less than 100, baby is not crying, baby is floppy, immediately start with positive pressure ventilation. As far as pediatrics is concerned, positive pressure ventilation is provided by bag and mask ventilation. It is provided by bag and I think we won't be able to see this thing. Let me write here. So if the heart rate is less than 100, you will have to go with bag and mask ventilation. Okay. What is the pressure of that bag and mask ventilation? This is one of the Neet question, very important. So initially you will be giving with 30 to 40 centimeter of water. The pressure which you give, see, you will have to press this no. You will have to press this no. The pressure which you will be giving is 30 to 40 millimeter. Initially the pressure is 30 to 40 centimeter. Subsequent pressures will be 10 to 20 centimeter of water is more than enough. Okay. Just go with 3 to 4 puffs. Just go with 3 to 4 puffs and immediately check the heart rate once again. Actually, one person will not be able to do this. Because since it is an emergency, as VCRR is what we used to do now, pediatric PGs will be giving this positive pressure ventilation, will be checking the heart rate, whether the heart rate has increased. See, from my experience, I'm telling you, just by 3 puffs, the heart rate will increase, bro. Just by 3 to 4 pressure, no, the heart rate will come back to normal. The heart rate will increase to 100, we can be relaxed. Okay, so this is first management. We'll have to give bag and mask ventilation. What we need to do, even if the heart rate doesn't improve, even after like positive pressure ventilation, we'll have to classify once again. If the heart rate has come back to normal, then we'll be going to the routine newborn care. Routine newborn care. I told you before, no, you will be going back to that. If the heart rate is still less than 100 or if the heart rate has decreased to less than 60, no, this is very, very important. Frequently asked the Neet question. If the heart rate is less than 60, you will have to do 2 things. One is intubate the baby. Number 2, give chest compressions. Start chest compressions. Okay, start CPR. Okay, fine. So the CPR of the baby, so this is how we intubate, and the tube, this is one of the anesthetic Neet question. The tube which we use for newborn resuscitation, like laryngoscope which we use for newborn resuscitation is Miller's tube, Miller's laryngoscope. or Miller's blade. Okay, just remember Miller, L and L. See, L is straight, which means the Miller's blade will be having a straight blade. For adults, it is Macintosh. It is Macintosh. See, the C is curved, which means for adults, the blade will be curved. You can expect an image-based questions, bro. Nowadays, image-based questions, clinical questions are booming. Factual questions are degrading. It is the era of complete clinical examination. If you do your CRI, you will be able to answer 60 plus questions just by having knowledge in your CRI. So make sure you do your CRI period properly. Okay, I should not tell this. Fine. Okay, this is intubation, and as far as CPR is concerned, no, we will have to be we are having some protocols that has to be followed when we are doing CPR. CPR of a newborn. This is very important. Once again, Neet or Inicet question. Fine. So how will we be doing CPR? CPR of adult is different. CPR of baby is different. How will be holding the baby is no. So assume this to be the baby. Okay, this is baby now. Assume this these two are the nipples of the baby. Just below the nipple, you will have to wrap the fingers like this on the back. You will have to give chest compression like this. See, by thumb you will have to give chest compressions. Okay, don't go to the xiphoid process. If you go to the xiphoid process, that might injure the baby. Okay, wow. So the CPR rate has to be nearly more than 100. Definitely you will have to give more than 100 CPRs per minute, and the ratio is 3:1, bro. 3 CPRs, 1 positive pressure ventilation. 3 CPR, 1 positive pressure ventilation. So when you take it for 1 minute, no, in 60 seconds there will totally be 120 events, which means each and every event will have to be 0.5 seconds. So I will have to give 2 CPRs in 1 second. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5. But every third 1, 2, 3 positive pressure ventilation. 1, 2, 3 positive pressure ventilation. So one person cannot do that. 2 person has to be there. 1 person will be doing chest compression. The other person will be waiting for positive pressure. Every third chest compression, you will have to give. Another person has to give 1 positive pressure ventilation. So 120 events la 90 events will be chest compression, and 30 events will be what? Positive pressure ventilation. So totally you will have to have 120 events in a matter of 60 seconds. Now assess the heart rate. So now you can see if the heart rate is more than 100, if the heart rate is less than 100. If the heart rate is more than 100, you will go back to routine. You can be relaxed. If the heart rate is still less than 100 or still less than 60, no, you will have to give adrenaline. Fine, you will have to give adrenaline. So this is how we intubate the baby. This is how we give adrenaline. Okay, adrenaline is actually given. See, this is how we give adrenaline. We look at the arteries in the umbilical cord. We give adrenaline. See, adrenaline dose for pediatrics is 1:10,000. Okay, we will be giving some 0.1 mics per kg. Adrenaline. This is the last step. This is what all we can do. Fine. This is all about today's class. Thank you.